Once we have this and we've learned to do that and to correlate, it's important that, what are we doing in everyday practice? So all these children, their parents have given consent for us to use their pictures to learn and to help us learn as well. We don't know what we see, I love this, but we see what we know. So once we know what we're looking for in the next baby, we are going to see it. So we started off like that, and it's a complete unknown ocean, and now there's some semblance of learning through these years, and we are constantly learning. So these are just some snapshots to show you the utility of the UBM and why we are all such fans of this. This is actually presented to us with primary angle closure for LI, and turned out to have just a high insertion on JOAG, and you see where the iris is inserted high up. So it's very easy to go wrong sometimes. This was somebody who came with trauma, with persistent endophthalmitis despite surgery, and finally when the pressures rose and was referred to the glaucoma department, something told us that there's something going on the gonioscopy. So it's just the clinical thing which makes you think about it, and it turned out that there was just this little piece of iron which was embedded in the iris, and I can assure you there's nothing else on earth which could have picked this up, and it was easy to just snip the iris away and take this out, and that's what was a better management. This of course is the garden variety of pigmentary glaucoma with a concave iris, which is seen very well on the UBM. And his pressures were very high, and he was intolerant to drugs. So when we did the LI, actually it helped. It doesn't help all, but sometimes you could see the effect of LI as well. This is something that we see. This is a plateau iris, and you can see that if you don't recognize a plateau iris, sometimes there's no effect of laser. And these pictures show us how the laser iridotomy, if you do it peripherally, the ciliary body is just sitting on the iris and pushing it up. So it's not going to work. And the UBM helped us diagnose the condition, and then we went on to do the iridoplasty, which is thermal burns at the base of the root of the iris. So this is just a snapshot of what all the UBM can teach us, and that's when we went on to the children. So there's no financial interest, but yes, there are lots of 35 megahertz UBMs going around. Now, this is a resolution with a 50 megahertz. You can see the iris cyst. You can see in a young boy a topiramate-induced angle closure. And these are the resolution with a 35 megahertz probe. So when you're trying to really make a decision of anterior segment and make a decision of management, I think it's well worth investing in a 50 megahertz probe rather than a 35 megahertz. And I can tell you a lot of the machines have 35/50. So it's important to do it on a patient, see it, and ask the company to show 50 megahertz images before you buy it. So this is a picture that Faisal also showed, which was actually on the cover of the journal, because it taught us so much about neonatal onset rubella presenting with congenital glaucoma, which we don't think of. Neonatal onset rubella, we think it is cataract and salt and pepper retinopathy. But we were surprised at how many of them turned out to be rubella positive. So we've already said this, we've no idea of what is behind. Now, this baby, for instance, it makes me a little okay about operating this neonate, because the only thing that is there is a really thick cornea, and probably with a combined trab with trab, he's going to be all right. And post-surgery, as the child grows, most of the cornea has cleared except a central bit which is scarred, which you can probably get away with just doing an optical iridectomy. And you can see how the cornea has reduced and the thickness has reduced once the pressures have come down. But all white corneas are not always primary congenital glaucoma. So we've seen a lot of Peters abnormalities. These are large Descemet's defects on both eyes, but the clinical clue is that little bit of central clearing in the cornea, which would make you look for a Descemet's defect on the UBM. But it's not always only a Descemet's defect. So this 3-day-old baby, and the left cornea is a little clearing in the center, but there's something that tells you that something is wrong, and it's looking a little cystic, in fact. So what this baby had was what we now call it a large corneal cleft, for lack of how to describe this, we started calling these corneal clefts. So you have these huge clefts within the cornea, and if you do the pachymetry, the cornea is very thin. That's because the pachymeter only checks the initial. So initially we were very worried before having the UBM that how come this is just a 200 micron cornea or a 150 micron cornea, but that's because there's this huge fluid pocket, and before we had the UBM we didn't even know what this was. So this is a large Descemet's defect with a large cleft, as we call it, and post-op again the cornea, the central, because it's a Descemet defect, it scars. But if you can manage to clear the periphery, we do manage to do an optical iridectomy while the baby is waiting for an OPK. And actually, this eye actually has 660 vision. Of course, had PCG in the other eye, which cleared completely. So these phenotypes overlap. You can have Axenfeld in one eye and Peters in the other with the same genetic mutation, because each one of them is interrelated, they regulate each other, so the phenotypes might be different in two eyes of the same baby. Now, even if it's the same disease, it could be very, very asymmetric, and that's where the UBM helps. So you can see there are Descemet's defect and there are corneal clefts in both eyes. But if I have to tell a corneal surgeon, I have to push him to do a PK, I'll tell him to do the right eye, because the anterior segment disorganization is less, and it helps right at the beginning to prognosticate. Now already if you have a flat AC and the iris stuck in the cornea, this is going to be a far more complex anterior segment, disorganized anterior segment, which needs to be treated right. So I would go for the right eye and maybe masterly inactivity in the left, unless they have to. Then the defect in Peters could be very, very large. So this looked very funny. I mean, this looked like a little balloon, and of course just primary congenital glaucoma in the other eye. And this Descemet's defect is so large that with the high pressure, the crystalline lens has gone and stuck in the lens itself. So no matter what you do, you know at the back of your mind that you'll be able to do something about the left eye, but the right eye probably is already gone. And though we did surgery and we it's not going forward. Okay. Anyway, so how does it matter? I had pictures of the post-op I would show you. All right. So if we see a cataract with glaucoma, that's the first thing. Think of rubella. And why that's important is, and sometimes like this baby, you can actually see that whitish thing beneath it, and it's seen better under the microscope. So this is in the OR under GA. So if you see it, it's not important that it's just a cataract and might be rubella. It's important because there are three systems involved: the eye, the heart, the ear. And there are many who we used to send, and now we understand that. We've sent for developmental delay. They're not developmentally delayed. They can't hear. So all they required was an ENT referral, and the BERA would show up as very, very diminished responses, and all the children needed was a hearing aid. And once they had the hearing aid in place, their world just opened up, and suddenly a developmentally delayed child was much more better, much more normal. So it's not just ophthalmology. It is possible to change what you're doing for the baby, because that baby you want to be as productive as individual for society as possible. So this, of course, was the UBM which taught us this, and it's the UBM which taught us that so many of them could have cataract. The other condition, of course, would be oculocerebral syndrome of Lowy, but that's completely different. You have sunken eyes, you know, the picture of a Lowy syndrome would be completely different, but rubella in our country with non-universal vaccination is a reality. So, of course, okay, so here it is, going back to the same baby. He landed up with an unsightly blind eye, though the left eye cleared completely as we thought it would, and this was the defect. So you need to know that your babies have a life, and we advised the parents to go in for an ocular prosthesis, because we didn't think that with this level of amblyopia and this level of disorganization with the lens there, this baby was not going to have too much vision, which was improving. And now he's grown up and he's actually enrolled into school. So you partner with them and you be one with the family, and you realize that sometimes you have to, with a heavy heart, know that there is only so much you can do, but there's more to the child than just the eye. And sometimes, again, we've started noticing these bad staphylomas. They come in the neonatal period. And what we started doing is doing the torch evaluations, and a lot of them actually have vaginal infections. So these are probably intrauterine perforations which happened in utero, and the mothers have been treated for chlamydia later. So this is something which we've seen lots and lots of strands going and converging at one point, which probably in utero itself has formed a staphyloma and come in front. So there are things that there's not much you can do about this, but at least you can tell the parent, and if nothing else, send the mother for a gynae evaluation. So when I have something like this, I tell the mother to go for a gynecological examination, and I'm amazed at how much of chlamydia urethritis there is that we don't even know about and we don't talk about. So this is not an IUGR, this is a secondary thing, I suppose, because there's nothing in the baby except this ocular abnormality. So sometimes you need to make these difficult decisions when you have this young girl with UBMs like this. So I wouldn't be too much in a hurry to touch the left eye. I presume she would be pretty much amblyopic with a long-standing, there's a cataract, there are iridocorneal strands and everything, but the right, on the other hand, looks relatively better. And with the optical iridectomy, she's going to school now with reasonable vision. We're not so fortunate with having a robust pediatric cornea service, which is difficult, but it's not fair to give up on the babies just because the corneas are not available or we have constraints. So we do these optical iridectomies while we are waiting for them. On the other hand, if you have intractable glaucoma with a persistent corneal scar after a combined trab with trab and your UBM looks like this, then you really push them, and these babies do well with a corneal transplant. So know what you push for. In a constrained resources, it's important to pick the children and then send, rather than close your eyes and say refer to the cornea clinic, because there are some which you know are not going to do well regardless. But we push some of the ones where the anterior chamber is nice, and we tell them that these are people who probably the children would do well. Sometimes the OPK fails, and even in a failed graft where they are referred from the cornea clinic sometimes to do a UBM and for them to figure out which would be a better. So she doesn't have glaucoma, but she's a failed graft from the cornea department, and you do the UBM and you realize that again the right has extensive anterior synechia of the iris, it has a cataractous lens also. I would say let this be and concentrate on the left eye, take the cataract out, reconstruct the anterior segment, and the left probably has a better chance for survival than the right one. So making decisions for these children sometimes gets to be very useful. Then, of course, Dr. Sirisha Faisal has talked about the congenital primary aphakia, both of them. So this is the silvery blue hue. Whether it's in Hyderabad or in Chandigarh, they look the same. We've learned to recognize them, and the UBM, of course, shows very thin cornea, which is dysgenetic, and no lens. And believe you me, you should let them be, because they are very unpredictable after surgery. So I'll just take you through a valuable lesson learned. Interesting, we learn every day. So this baby came to us with the history of trauma, and there was this worm-like thing, and the mother was distraught, ki keeda ghus gaya. So, there's a worm in the eye, and there was hyphema. So this was funny because the other eye looked completely normal, and we said, okay, let's take it up. And for some reason, I said, let me look beneath the iris and let me see what's there. So we did the UBM. So this is what it looked like. You can see the hyphema, you can see that little worm-like structure. And this is under the microscope, and there was a little bit of corneal diameter was all right, 12.5. The pressures were a little high, 18 in one eye, and the other eye showed multiple strands actually. So it's the phenotyping which is important. Now, the gonioscopy of the left eye, the right eye I didn't see too much, but the gonioscopy of the left eye showed these characteristic anterior iris processes, and we call them Y-shaped processes because they go up and then they sort of get out into Ys, and that's our sort of eureka moment of Axenfeld Reigers. And we said, my God, this is what we're dealing with, and is that a detached Schwab's line? And then we said, okay, let's do the UBM and see, and sure enough, you can see this iris was pulled over a normal looking pupil by a Schwab's which had detached and had caused a hyphema. So the UBM really told us that, look, all we need to do is probably cut off this redundant iris which has come on top of this. So we used a vitrectomy cutter and we did a pupilloplasty sort of thing. So we really were fishing through waters which were largely unknown, but we probably had a bit of an inkling. So we took that little bit of hole that was there. So you can see that is the Schwa base, which has completely detached. And we inserted the cannula in that hole because we knew now with the UBM that the lens is probably clear and the pupil is normal. And we wanted to be sure that we are not going to cut the lens. And once we ballooned up the iris, slowly with a very, very slow vitrectomy cut rate, you can almost see, you can count the cut rates and you can see slowly the pupil is coming into. So this was just an iris fold which was over the pupil. And we just cut away that fold which was there, and this is an absolutely normal pupil underneath with the sphincter intact. So next morning, to our delight, this is what the eye looked like. So we were so happy, and everybody was so happy looking at him that, look, this is what the UBM did for us. So sometimes you learn, and then we examined the mother, and she had an Axenfeld anomaly, but normal pressures, normal discs, but an Axenfeld anomaly nevertheless. So then we are going to look at doing the genetics for them. And we thought it was fine, and this guy is now 4 years old. Now you can see the hypodontia, because he was such a small baby we couldn't make out at that time. There's hypodontia, there's a flat nasal bridge. You can see the iris processes now, and you can see the discs. So now everything fell into place, and we realized we were dealing with Axenfeld rigor. And while we were patting our backs, we had another baby with a complete ACORIA, and here were the iris processes, not as robust as the other one. But we thought, okay, let's go ahead and look at the UBM. It really shows that this iris is now adherent to the lens. So this is something to be very, very careful of. So we decided to do a pupilloplasty, but maybe in one side, because we didn't want to touch this part of the iris, and we thought if we can just cut this and make the iris go down, maybe we could salvage the lens or protect the lens and maybe do a pupilloplasty if we could. So anyway, we tried that. We went right in, and what we planned was to do it inferiorly so that we don't touch the central part of the lens. And what we did was made a certain eccentric sort of pupil. At least the axis was clear for some days, but alas, it didn't last long. And as expected, this lens did opacify. So she underwent cataract surgery with an IOL, and now at least with extensive patching, there is some ambulatory vision as well. But, and then we had another one. So sometimes they do come in crops. So this we learned our lesson better. And again, attaching to the lens, again the same iris processes, other eye normal, which underwent a goniotomy. So this time we were more careful. We went even more peripherally, and now this baby is about 3 years old. I'm very wary of touching the clear lenses of these children. So this is something which we always keep in mind. But with the patching, she's 2 years later, she's 6'12", and the left eye also has undergone a goniotomy. So sometimes it's just that knowing what it is helps you plan your procedure and plan what you think would be best for the babies. I'm not saying that they'll all be fine forever. We'll keep them under follow-up, but at least we do the best. So this was our learning point with Axenfeld, all learnt by using the UBM in the OR at the time of an EUA. They are all not developmental glaucomas. This one has been was referred to us with PCG, but on asking a history, the mother said it's a fingernail injury, after which there was a lot of redness and watering, and then it subsided. So sure enough, there you can see a full thickness corneal scar with the Descemet's membrane intact, but the pressures were okay, so we sent this to the cornea department because there was no glaucoma in her. Just as a parting shot, this is a child with silicone oil, and this actually is the silicone oil there, and this illustrates beautifully what we know. So the convection current of emulsified oil going into the angle and telling us why there is glaucoma in emulsified silicone oil. So To summarize, imaging the angle and anterior chamber has changed the management, and more rational, more informed choices of management are possible. But then we use technology as an ally, not as the master, and we can't use it in isolation. Thank you. So I'd be very happy to have some audience interactions. Any experiences which any of you might have?